Diabetes is a significant risk factor for atherosclerotic cardiovascular disease and is associated with lipid abnormalities, including increased levels of low-density lipoprotein, or LDL, and triglycerides, and lower levels of high-density lipoprotein, or HDL. Dyslipidemia may affect 75 to 85% of patients with type 2 diabetes. It is an independent risk factor for atherosclerotic cardiovascular disease. Therefore, holistic management of type 2 diabetes should incorporate lipid management. Regardless of the presence or absence of dyslipidemia, all patients should be encouraged to have a healthy diet, undertake 30 to 60 minutes of physical activity daily, and avoid tobacco use. Beyond this, treatment of dyslipidemia in patients with type 2 diabetes largely depends on a patient's risk of developing cardiovascular disease. This can be estimated using the Australian Absolute Cardiovascular Risk Calculator at www.cvdcheck.org.au. All patients with more than a 15% 5-year risk and some patients with a 10 to 15% 5-year risk for cardiovascular disease should undergo lipid-lowering therapy as per the National Vascular Disease Prevention Alliance guidelines. Guidelines from different bodies diverge on precise definitions and cutoffs for low, moderate, or high risk of cardiovascular disease, as well as treatment targets. To reduce the risk of atherosclerotic disease, it is reasonable to aim for LDL of less than 2 millimoles per litre for primary prevention, LDL of less than 1.8 millimoles per litre for secondary prevention, triglycerides of less than 2 millimoles per litre, and HDL greater than 1 millimole per litre. Statin therapy remains the cornerstone of treatment. Statins are particularly effective at lowering LDL cholesterol levels and reducing triglycerides by 10 to 20%. High-intensity statins, including atorvastatin 40 milligrams or more and rosuvastatin 20 milligrams or more, are expected to lower LDL by an average of 50%. Moderate intensity statins may decrease LDL by an average of 30%. Muscle-related symptoms may occur in 10 to 15% of patients, but these largely occur without elevation in creatinine kinase or major functional loss. Rhabdomyolysis is rare, with 13 cases per 100,000 patient years. Ezetimibe inhibits intestinal uptake of dietary and biliary cholesterol and has additive effects on lowering LDL with statins. It is a second-line therapy when targets cannot be achieved on statins alone. Evolocumab is a newer PCSK9 inhibitor used for refractory dyslipidemia. It is now available on the PBS for patients with diabetes who have an LDL greater than or equal to 2.6 millimoles per litre, despite maximised doses of a statin and ezetimibe in the presence of atherosclerotic cardiovascular disease. In addition, they must be over 60 years old, have microalbuminuria, or have Aboriginal or Torres Strait Islander background to qualify. Evolocumab is given as a fortnightly or monthly subcutaneous injection. It must be initially prescribed by a specialist, but continued scripts can be provided by a GP. Although fibrates such as fenofibrate do not have conclusive mortality benefits, they are effective at reducing triglyceride levels. Fenofibrate has also been shown to decrease the progression of diabetic retinopathy. In summary, cholesterol management is important in patients who have diabetes. Initiation of treatment largely depends on patients' calculated risk for atherosclerotic cardiovascular disease, and medication classes include statins, cholesterol absorption inhibitors, PCSK9 inhibitors, and fibrates.